Hello, my name's Rebecca Bushby and I'm the lead nurse for VT prevention at Ashford and St Peter's Hospital. Welcome to our World Thrombosis Day podcast. Today we're going to be having a chat about the under-recognised effects of VTE, and I have with me the lovely Emma G.
Thank you very much for inviting me today, Becky. My name's Emma G. I'm a nurse consultant in thrombosis and coagulation at King's College Hospital, and I lead the National VTE Nursing and Midwifery Network.
Thank you. And we also have the lovely Jackie Rees with us.
Hello, Becky and Emma. I'm the Associate Director of Quality for Ashford and St Peter's Hospital, and I've and previously Head of Patient Safety here. So I'm really pleased to be having this conversation today.
Marvellous. So, we just wanted to touch on, in particular, most people know about VTE, who work in clinical environment, and also patients that come into hospital have quite a good awareness about VTE, deep vein thrombosis and pulmonary embolism. And we've got quite good in terms of diagnosis, management and treatment. But what I wanted to touch on is that we often treat the patients for their acute episodes, and it's then what comes after that for the patients.
Yeah, no, I agree, Becky. I think the treatment now is so quick and easy because we have the direct oral anticoagulants that we're able to manage the vast majority of people as outpatients. So the time that they spend in hospital with us is just the very tip of the iceberg. And initially, when we first diagnose their thrombosis, it may be quite a shock to them, and they may need a little bit more time to process that diagnosis and what it means for them. And sometimes we find with our patients that all of the questions actually come a little bit later, and when they've had time to think about it, have to think about the impact that the clot and the treatments are going to have on them. And I think that it's easy to think once we've diagnosed the clot and started them on treatment, that's it, they're safe, they're treated. For us in the healthcare profession, we feel reassured that there's a low risk now of the clot embolising or growing. However, for the patient, it's all just beginning. They've got to get their head around this diagnosis. For some people, it's going to have a big impact on their quality of life. It may even have an impact on their employment and what job they're able to do, certainly in the short term and maybe even in the long term as well.
I mean, do you think that we give them enough information on the impact? I mean, the thing that you've just pulled up is about what job they can do, and even I'm thinking about that now in relation to VT, and I can't imagine actually that would have an impact on the job that I could do. And as I can imagine if it was a particularly active job that there might be some issues. I mean I can imagine them really wanting to explore that.
Yeah, absolutely. There seem to be quite a lot of lifestyle things that come out for people of all ages. So with regards to employment, it will depend on what type of job they do, partially because of how fit and able they are once they have a diagnosis of a DVT or pulmonary embolism. And then secondly, the implications of being on an anticoagulant. So if it is somebody who has a very physical job and maybe a little bit more higher risk of having an injury in that job, then they may well decide that risk while they're on an anticoagulant is not one they're willing to take. We've done some work with the London Fire Brigade and looking at firefighters who are on anticoagulants and helping them come up with sensible protocols that mean that firefighters are still able to do their job and minimise the risks. And that's all through timing of their DOACs. And the London Fire Brigade have been fantastic at enabling people to continue in their jobs wherever possible. Yeah. Becky, do you see many people with lifestyle implications?
Yeah, definitely in terms of their employment, particularly if we're looking at police officers, prison officers, occupations where there could be a high risk of physical contact. Patients who are on long-term anticoagulation or even in the short term, that can affect their operational capabilities. So you've got to take into consideration the fact that they may or may not be able to work, but then I don't think we often appreciate how that will then affect their mental health. after that, particularly if they have to make a long-term change.
Absolutely.
And then also we see the patients who may have had their acute thrombotic event and then they need to come into hospital for another reason. And then of course they can and do suffer anxiety about what's going to happen in terms of any treatment they're having for something else. Could that potentially provoke another event, particularly if they've had a rather large thrombus, you know, that could have potentially have been fatal. It really, really does have an impact. And often, if a patient's coming back into hospital like that for another reason, they won't necessarily mention to the healthcare professionals that are looking after them for that thing about their anxiety that's related to their previous thrombus.
So what do you think makes them anxious in particular? I mean, you've said okay, a recurrence. I mean, that's because that must be a chronic form of anxiety. Is there anything about how we talk to patients about their risk after they've had their treatment? What do we do now? I just wonder whether or not some of that anxiety is through lack of information.
I do think that there's an element of sometimes the patients may feel that the clinicians are maybe being a bit dismissive of the fact that they've had a previous thrombosis and that maybe the clinicians don't think it's relevant for whatever they may be in for now. And of course that then makes those feelings worse because they feel like they're not being heard or considered. I've certainly had patients express that to me if I've gone up to see them while they're an inpatient for another reason. Or it could be, you know what, often when someone's diagnosed with something, they know an awful lot about their condition, don't they?
Yeah.
They know an awful lot about it, and they want to be reassured that the people that are caring for them have the same level of knowledge that they have.
And if there's any sign of that not being the case, I can imagine that they start considering having to almost look after themselves in a hospital environment and check. And maybe that sometimes that might come out as a particular set of behaviours that people respond to.
Yeah, and I think there's also different scenarios. So there'll be patients that have an existing condition that could predispose them to clotting, and they know it's a risk that it may happen. And then when it happens, or if it happens, it's not so much as a shock to the person where it's a sudden, acute, unexpected, unprovoked event. I don't know if you've seen anything like that, Emma, in your practice.
No, absolutely. I think when you look at a lot of the research around psychological impact of VTE, it has shown that some people that don't have a good reason for getting the clot, it came out of the blue, it was essentially unprovoked, find that they perhaps struggle a little bit more to get their heads around it because there isn't any, other than being on anticoagulation, there isn't anything they can do to reduce that risk. And therefore, because it appeared out of the blue last time, they live with that constant threat sometimes hanging over them. You know, is this little niggle going to turn into something bigger? Should I get this little niggle checked out, or is it because I went for a run yesterday, for example? And I think it's interesting that you touched on information, Jackie, and I think that's something that we could probably do a lot better on. I think that it's quite complex, and when you start sort of really looking at how we optimise it, there are issues about certainly any information given needs to be individualised, and you know that we all know that because there are so many different variables. I think timing as well is quite a big issue. When somebody's first diagnosed with a clot, that day they may not be in a good position to take on and digest a lot of the information that you give them. I think in healthcare we love a leaflet and we love giving it. We've got leaflets at everything and we give them out to people who end up with a big carrier bag of stuff to take home. And I think there are probably people who read leaflets and people who don't. And also people who perhaps want more information and people who want less information. So I think it's quite difficult to get it right, and I think maybe we need to be a bit more creative about the mediums that we give information, particularly right now during COVID pandemic, it probably isn't ideal actually that we've got loads of leaflets lying around everywhere that we're giving out to people, and maybe we need to sort of, you know, become a little bit more savvy about how we give information to patients. And I think one of the most important things though is that patients have a point of contact. It's like I say, I think often it's when they get home and they start telling people and start really processing that information that then they think, oh, I didn't ask about whether I can continue to play football or do weights in the gym, or what happens if my gums bleed when I brush my teeth, and all these sorts of questions that come to patients afterwards. And then they think, oh, well, I've got to wait another week, 2 weeks, or however long until I have my appointment. And I think that's the challenge, isn't it? Having the information there for patients in the way that they want it, when they want and need it. Have you got any thoughts on that?
Well, I think what I've seen that's really interesting, and I don't know if you'd agree with this, or Jackie, actually, in some of the stuff that you've seen, is that there are some very, very active patient groups on social media, particularly around thrombosis, and some of them are really good. They've kind of set up their own support network, and you can see the questions being asked and people providing support, people that have been through it already, giving support to people where it's something new for them. And I think that's really good. But conversely, I sometimes see information on there that isn't accurate and isn't helpful. And it's about, is there a way that, particularly now, like you say, in the COVID pandemic, is there a way we could use these virtual platforms, whether we set some up ourselves or we make use of the ones that are already there, but is there a way of doing that safely? I think it's tricky, and I think I've had discussions before around, I don't think there's enough provision in terms of patient support afterwards for things like mental health and things like that around, but it's how's the best way to deliver that, because again it needs to be individualised to the person and their experience, and it's how would you be able to deliver that to everybody. Not everybody would need it, and not everybody would perhaps welcome it or want it, but there would certainly be a huge group of people that it would be very beneficial for, certainly for, like I say, the things I see on social media. But then we also have resources like Thrombosis UK, and you know, the patient information they have is brilliant. They put out patient stories, they've got video clips, they've got some fantastic resources on there, as have World Thrombosis Day campaign. So, you know, maybe we need to make more use of those resources that are already there as well.
I mean, there is an element of information overload, isn't there? And I can understand perhaps that, you know, when you come into these social media groups, that you will have the experts that raise, or the expert person that has been through it, and you will have misinformation, and it's encouraging people to put these things into context. And I think that's a very individual thing. But in terms of the psychological impact, then that's a different thing. Do you necessarily need, when you're talking about helping somebody psychologically to come to terms with their diagnosis, is that a different expertise that's needed? I mean, and is that available?
I think sometimes you're right. I think you do need somebody who has a little bit more specialist experience and knowledge about managing psychological conditions. At King's, we hope to soon implement as part of their Mind and Body programme, an imparts tool whereby anybody diagnosed with a deep vein thrombosis in our outpatient clinic will have an assessment whereby they self-complete a questionnaire looking at various questions around their maybe depression or anxiety, and then that will just help us highlight any patients who might be in need of a little bit more support. We'll have a protocol so that if they score a certain amount that triggers something, then they will then go on a pathway that makes sure that they get access to the type of help that they need. So in doing that, we hope to provide a bit more holistic care for those patients. I think at the moment we probably are doing quite a good job as nurses in listening to our patients and understanding their needs. But I think there will always be patients who maybe don't feel comfortable or don't know the right kind of language to actually express that to their nurses. And everybody is aware of the time pressures as well that we're all under in clinic. So there will be people who look like they're coping and perhaps go under the radar. So it'll be really interesting when we implement this to see if there are people like that need help and perhaps haven't asked for it in that normal setting.
I got really excited when Emma mentioned that the other day.
Yeah, it sounds really good,
fabulous.
particularly the anxiety part of it, because you'll have different levels of anxiety, won't you? Anxiety is part of life, actually,
Absolutely.
isn't it?
Absolutely.
But it's filtering out those whose anxiety will be allayed with some extra information and some understanding, and those that maybe need to a few strategies to help them cope with an excessive amount of anxiety.
So I was going to say, I think you're quite right in what you're saying, and actually, do you know what? Some people will just need that little bit of reassurance to know that it's okay to feel a bit scared.
Yeah.
And it's okay to feel a bit, there's nothing to be worried about, and it's perfectly okay to be concerned and feel a bit scared and a bit cautious, and likewise, it's okay if you don't feel like that.
Yes, that's right.
I think it's about normalising all of these reactions are fine, because again, everybody's experience is individual and different, and there'll be lots of other things going on for them that may or may not be impacting on how they're feeling and what's going on. And I think, you know, sometimes people feel they should be feeling a certain way or they should react in a certain way to a diagnosis or something that's happened, and if they're not doing that, they then feel that something's wrong.
Yeah, I think that's right. I think that the way people cope must be put in the context of them, their personality, their past experiences. And interestingly, when I did some research looking at the patient experience of pregnancy-related VTE, there was a lady I interviewed who had a fairly significant sized pulmonary embolism, and actually the first she was aware of it was that she fainted on a London bus, and she went to hospital and she was diagnosed with this PE, and she very much took it all in her stride, and she said she thinks that's because she had previously had breast cancer, and so in contrast, she didn't feel like this was anything for her to worry about, because she was put on treatment, she knew exactly what was happening, and she didn't have that uncertainty that perhaps she felt when she had breast cancer over, well, will it go, and will I be okay? She felt quite confident. And conversely, I also interviewed a patient who had quite a small distal DVT, who had never experienced anything like this before, had never been in hospital, and was highly anxious, and this anxiety, I think, was probably exacerbated by the fact that her baby had some complications. She had a difficult birth, and then afterwards she couldn't shake off this feeling that she was high risk. So even though she finished her treatment, if she went on a long car journey, she would have an injection of low molecular weight heparin to reduce her risk of getting a clot, even though that wasn't something as healthcare professionals we would suggest. But she just felt like, that the level of anxiety isn't proportionate to the perceived risk, certainly from healthcare professionals. The size of the thrombosis, the extent of the risk to the patient's health is not always reflected in the anxiety and the psychological impact that they feel, which is probably the case for most conditions, isn't it? We could say it's in the context of that individual.
Yeah. And I suppose if you're I'm given that it's in maternity, given you're likely to be a reasonably young person, that must be a shock when it comes out of the blue. I can imagine. I suppose you can only try and put yourselves in their shoes, can't you? Yeah. And if I reflect on my own experience, I didn't imagine for 1 minute that anything was possibly going to be happening to me. Not that it did, but that was my mindset. So, I think that. Did she say what? When you did your research, did you get any feedback about what helped? Were those people able to say to you, well, actually, what put things in more context for me, or what sorted out my anxiety was?
Yeah, generally information was probably up there, and I think also having confidence in the care that they were given. For many of them, they had difficulties in getting the original diagnosis. I think that has a lot to do with the fact that it's very difficult to diagnose VTE, particularly in pregnancy, and lots of other things that are going on can mimic the symptoms of pregnancy. So a lot of them felt like they'd had to go back again and again to healthcare professionals with their symptoms. And a lot of them subsequently said that actually the whole experience had given them a sort of a drive to be a little bit more assertive in future about their health and trust their instincts when they think that there's something not quite right. But yeah, in terms of what helped them, I think a lot of it was to do with their own support, their own family support, but information. I think most people felt like they could really deal with anything if they had the correct information.
And were they specific in the types of information they said they would like, or was it very different across the board?
I think it varied quite a bit. I remember that one lady was quite concerned because she wasn't given enough information about having a scan to diagnose pulmonary embolism. She was very upset about the potential risk to herself and her baby. This was during pregnancy, and she found it difficult to get the information. She wanted quite specific information about the risk, understandably, before she went ahead with the scan. But for others, I think it was more to do with the impact it might have on their baby, and it depended where they were diagnosed. So those people that were diagnosed in an outpatient setting generally were happier, because I think that it was a specialist setting that they were diagnosed in, and with specialists who had the time to go through all of the information, were probably a little bit more aware of the types of things that people want to know, particularly during pregnancy. Ultimately, it's going to be, is my baby safe?
Yes.
Are we both going to be okay? And one lady said that after her diagnosis of a distal DVT, she went home, told her partner, and they had a serious conversation about whether to continue with the pregnancy. And that just shows that they hadn't fully appreciated or perhaps hadn't been able to take in the fact that there was no risk to the baby, or very little risk to the baby in her taking anticoagulation for the clot. But I thought, what a shame that they had to go through all of that trauma together when actually, she could have asked one question, or we could have given her that little bit of information that would have just completely put her mind at rest about that. Yeah,
I suppose it's about then having that opportunity, isn't it, at a later date after the initial diagnosis, to be able to have those discussions and ask those questions once you've had time to process the information.
Do we offer those types of follow-up information giving type appointments? Is that what we should aim to do?
Definitely. I think, we do follow our patients up, but I think, like I say, when those sort of issues come up in people's minds, it might not be okay to wait a week until the next appointment.
You said that.
And I think that some sort of in an ideal world, a helpline or an email address that you can get a quick response from would probably be something that would be helpful. How about you, Becky? Have you got something?
I like the idea of there being a helpline or a virtual clinic or something like that, where it can be, because I think emails are great, but sometimes they can get misinterpreted, particularly when you're giving information back to people. I think sometimes having that conversation, even if it's over the phone or via some sort of virtual portal or something like that, I think that's often more reassuring almost to people. And I think when you're having the conversation and having the discussion, it sometimes prompts people to think of something that they wanted to ask and they might have forgotten, and something triggers that question. And also knowing that at any point, if they need to, they can phone this number or make an appointment at the virtual clinic tomorrow, or just having that accessibility. So again, like you were saying, they don't have to wait 2 weeks, because then of course you know, people will try and seek out information
Yes.
from other sources
Yeah.
that
Yeah.
perhaps might not be helpful.
Yeah, absolutely. Yeah.
I don't know if you ever see that. We see that sometimes with people.
Yeah, people come in terrified because
yeah.
they've read something online. And obviously there is a lot of really good information on the internet, but it is very hard to actually sort through what is good quality information and what
Yeah.
isn't. And then for somebody to then understand if that is applicable to them and if that takes into account all of their little nuances is very difficult, isn't it? It's very general information that you see online, isn't it? But it can be scary for some people. I think that risk of recurrence is one of the things that you see regularly in clinic myself, and also throughout all of the research that's been done looking at patient experience and psychological effects. And as I said before, because the symptoms of DVT-MPE are fairly broad, you can just get a niggle in your leg or a little bit of pain, quite non-specific. It does then lead people to wonder, at what point do I get help? What point do I take this seriously and check this out? Because once people have had a clot, generally then they understand the most serious risk of having a clot, i.e. having a fatal pulmonary embolism. And it can be quite difficult sometimes. I think the thing that we always tell people is that if those symptoms are consistent and they don't go away, or I think if it's causing you sufficient worry and really sort of upsetting you because you're very anxious about it, then it's worth getting checked out just to put your mind at rest.
Yeah, I think that's really, really important. And sometimes, you know, I've had patients say to me that they've had something that felt very much like it felt last time, but because they had something similar a week ago and they came into A&E for it and it was fine, they didn't want to come again because they didn't want to worry anybody. They didn't want to be seen as, you know, being overcautious about everything. It's about giving that reassurance that, you know, that really, really isn't the case. And again, during the pandemic, you've got the other added extra thing where people don't want to present, particularly if they're unsure if anything's actually wrong. And I think that adds another element into that kind of anxiety and those feelings of being unsure.
Yeah, absolutely.
And they're probably also, if they do present once and they come into a department that they don't perceive as safe, COVID safe, I'm thinking, then they may think twice about coming back. I mean, most places are pretty well organised around COVID, but sometimes the patient's perspective is slightly different.
Yeah.
And, you know, it's important that the social distancing is right at the front of people's minds all the time for anyone that's coming through those doors, just in case they need to come back again if they want to re-present. I mean, have you seen? I mean, Becky in particular, you will have seen some phenomena around the impact of COVID and the effect that it's been having on just the psychological effect on our patients. You know, what sort of things have come to the fore for you?
Well, definitely the level of concern amongst patients, particularly patients who are on anticoagulation long term and patients who have had previous thrombus, because at the beginning of the pandemic there was obviously a lot of media attention around the increased clotting associated with COVID, and there was a lot of reporting done on that. Some of it really well reported it, some of it not so much.
We had the issue that patients, so many of our patients, particularly on warfarin, were shielding. And obviously in the national shielding letter, there was a caveat that if you had to attend important medical appointments, then obviously that would be okay, and that would still be, you know, deemed necessary. But of course, our warfarin patients were concerned when they were told to shield, and we were saying, no, but you still really must come to the hospital. It's really important that we check your INR when you're on warfarin to keep you safe. And a lot of people assess the threat of COVID to be greater than needing to be monitored on warfarin. So for some people, it did take quite a lot of persuasion to come and get tested and to, reassure them that the hospital was as safe as it could be.
Yes.
In terms of actually the phlebotomy departments were very, very quiet at the time.
Yes.
And easily able to socially distance.
Yeah.
I mean, obviously you can see with all of the media attention, you can completely understand the concerns that people had. And I think that patient group wasn't alone in assessing COVID to be a greater risk than what other comorbidities they had. And that's part of the concern about all of the collateral damage, isn't it, throughout COVID, that other patients didn't necessarily get the treatment for their other comorbidities. Yeah, so we definitely saw some patients, that probably was what we spent most time on actually, was just making sure that all of our patients that needed monitoring were safe. And then in terms of people coming to the hospital, we definitely had a lot fewer patients come into the DVT clinic. But interestingly, the number of clots that we were diagnosed were not going down. Like you say, unfortunately, there is an association with COVID and thrombosis. So we were seeing a lot more hospital acquired thrombosis in patients that had got COVID. And I think for them, it's a double whammy, going back to the whole psychological impact. There's been so much in the press about long COVID and how it can take some people a long, long time to get over COVID. And they've also got to deal with, in a lot of cases, a pulmonary embolism, which, as we know, can cause fatigue and sometimes respiratory side effects for months. And it was difficult for them to distinguish what was caused by the COVID and what was caused by the clot. But, scary times for people.
Yeah, really.
So that's a big thing, isn't it?
Yeah.
I think it's really scary as well for people's relatives and for
Mm.
carers as well, particularly if they had relatives who had quite a significant thrombotic event prior to this. There was definitely an increase in concern about what would happen.
If they caught COVID, yeah. I mean, I'm interested in the age range really for COVID, and I don't know whether or not there was more of an impact on the older age range of COVID. I mean, was it the same if you came in with it? Were you more likely? Was there an age range? I mean, I'm probably putting you on the spot here, but have you got a feel about whether or not the risk of that clot was also linked to the higher aged population?
I think it was more linked to the severity of their illness.
Yeah.
So those people that were admitted to critical care were much more likely to have thrombosis. And to that end, when we realised that, we changed our thromboprophylaxis protocols at Kingston, and a lot of other places did, just in critical care, because they were deemed to be much higher risk. We increased the intensity of thromboprophylaxis.
Yeah. So in terms of pregnancy, what was the prevalence there then? Did they suffer, pregnant women, did they suffer similar issues as the rest of the population
during COVID?
Yeah, during COVID.
Well, initially I think the RCOG were very concerned, weren't they, about women in pregnancy, and there have been a lot of guidelines submitted, which I think that's helpful. But as with every aspect of our life at the moment, the fact that they kept changing as they became more and more knowledgeable, it's been difficult for us all, hasn't it, to keep up with ever-changing rules. But I think that pregnant women generally have fared quite well, actually. I think those that have got COVID during pregnancy, generally speaking, have been quite well and have had very limited effects on their pregnancy,
really
which is good news. Yeah. Have you found the same?
Yeah, I mean, I'd agree with what you said. I think the correlation was with the severity of the illness rather than it particularly affected this group in terms of thrombosis and COVID. I mean, I did have some colleagues in other hospitals who were saying anecdotally that they'd seen an increase in younger men. So kind of the 20 to 40 age bracket. We didn't see that here. It was kind of very well spread out across gender and ages for us, and like I say, it was more related to the severity of the infection and how much intervention they needed actually, because of course some of the interventions that we do increases the
Yeah.
the thrombotic risk. So trying to balance that out, particularly in this sort of scenario, is
And
be
Jackie,
tricky.
from a sort of patient safety point of view, obviously when people come into the hospital, the last thing we want to do is give them any additional problems, such one of which being VTE. But often I think we are really focused on working to perhaps in silos a little bit to reduce the risk of VTE to our hospitalised patients. But obviously you're concerned with all risks.
Yeah.
Is there a way, do you think, that we could work better collaboratively to make sure that we, instead of everybody fighting their own little fires, that we could work together to reduce the risk of all potential hospital associated harms?
Yeah. I mean, I think that's a light bulb moment that has happened in this organisation in terms of our the appointment of the first consultant nurse for hospital acquired harms in the UK, to bring together all harms, including VTE, pressure ulcers, the nutrition, the hydration, all of those issues that patients have in hospital, and if you're not looking after one part of it, it'll affect the other part. So if you're not hydrated, it increases your risks elsewhere. So, and I think that's probably the very early steps, I think, towards a hospital-wide strategy and approach to harm. I think we're just about to publish, I think it's just been published actually, our strategy. And it's a developing phenomena for us. And I don't, if I'm perfectly honest, I think we all understand the power of putting working collaboratively. The output of that, we're just in the process of understanding the impact that we're able to have. Because in the end, most people will want to know what your outcome is, won't they? It's all about outcome, and rightly so. But there's also a big patient experience piece in there, in terms of the care of our patients as a whole. So I think VTE is, I'm really excited. I'm really excited about, we've got this big team. Becky's a big part of that team in terms of her specialist knowledge in VTE. And I think we've got a lot more work to do. I think our medical colleagues also could need to be almost pulled into that team, so that's a multidisciplinary team. And we're not quite there yet, but I think they're the next steps, because that multidisciplinary approach is extremely powerful. So I think we've got lots of work to do. But I don't know whether there's any other hospitals in the UK that are thinking of it, but my understanding so far is that our consultant nurse for hospital acquired harms is the first.
Yeah, I know, that'd be really great to see how that develops, and like you say, what the outcomes are like, and like I say, somebody who can pull together hopefully the multidisciplinary team, because as well as doctors and nurses, obviously pharmacists have a big role, physios, OTs, dietitians, everybody has a big role to play, don't they, in maintaining patient safety. And I think it's just the fundamental right, isn't it, of patients who come into hospital, and expectation that they will leave the hospital unharmed in any way.
I think there's also the expectation that you'll leave unharmed, but I think there's also the expectation that you will feel safe.
Yeah, absolutely.
I think that's really, really important as well.
And that's part of the patient experience thing. That's a cultural piece, isn't it? That you when a patient is surrounded and can see themselves surrounded by a cohesive multidisciplinary team who are looking at them as a whole person, psychologically as well as physically.
Yeah, definitely.
Then I think that's where we're aiming for, isn't it?
Yeah. I think that hits the nail on the head.
Clinical
really.
Psychologists in every department.
Yeah.
My husband works in orthopaedics, and he has trauma patients who come in and they've experienced a huge, say, motor vehicle collision or another big catastrophic injury that might leave them with life-changing injuries. And sometimes I'll say, well, who's seeing them? Surely you've got a psychologist coming to speak to that patient, you know, almost from day one, to help them. I mean, goodness only knows what must go through people's heads when they've been through that, and so many unanswered questions, so many questions about their future. You know, I think same for a lot of patients in hospital with a new diagnosis, like our VTE patients. It's thinking about the future and their role as, you know, perhaps in their family, perhaps they're the provider or the mother who has to keep everything going the whole time. As mothers, we all know that you only just got to let one of those plates stop spinning and everything falls apart. So I think, clinical psychologists in every department, just to be there for when patients do need them is
interesting you
ideal.
say that. So I started my career out in accident and emergency, and when I moved from accident and emergency and urgent care, I moved into critical care. And then I went into critical care outreach, and I always remember I moved to a different hospital and they had a follow-up clinic with a clinical psychologist for all of the patients who had had a critical care admission. They didn't have to go to it, but if they wanted to, it was there. And we would go as well, particularly if we'd seen the patients in follow-ups on the wards. And I was so astounded, not only by the need, but to see the improvement and the effect that those sessions had in a relatively short period of time. They were so beneficial for people, particularly for people that had had a sudden event of some sort and had a sudden critical care admission. And
the mind and body are inextricably linked, and we know that, and yet we persist in treating the physical symptoms and maybe skirting around the psychological symptoms, or perhaps doing what we can do, but as soon as we feel a little bit out of our depth, because perhaps we haven't had the training in psychological conditions, then maybe backing off a little bit. So I think that it would be great if we all had somewhere that we could refer our patients to for that extra support when they need it. And for patients, for it to be well known so that patients could self-refer as well, because like I say, sometimes they don't feel comfortable or don't necessarily need it at that time, but maybe later on. But
I mean, are there other models? Are there other models in place, you know, around the country? Because of course, you know, many people like to take from what, you know, from a model that already works or has been tested out, and the difficulties have been ironed out.
I'm going to talk to you a little bit about the Mind and Body programme at King's Health Partners, and it's already in place in lots of specialties at King's, and some specialties have been using it for years, and it's brilliant. Off the back of it, a lot of people have been able to, a lot of departments have been able to submit business cases for clinical psychologists or psychiatrists. Some of them are charity funded, and some of them have been funded by the hospital, but you know, they've quickly been able to show the need, and therefore it has been funded going forwards. And I think once you have somebody like that working in your department, you can then never do without them.
Absolutely.
And like I say, the two go hand in hand, don't they? If you treat the mind, the body will get better. And I think, you know, to treat them in isolation is not helpful, really. I think that's probably...
Sounds like there's something coming at Ashford and St Peter's,
doesn't it? I think that's actually a really good point to end on, actually.
Yes, a paper from Becky.
Food for thought. And some work for Becky. Well, thank you very much for joining us.
Oh, thank you.
It's been a pleasure.
And thank you guys for listening.